Good morning, everyone. Today we'll be walking through a little bit of a COPD review and some of the implications this disease has on our nursing practice.
First, it's important to understand the pathophysiology of this condition and how it's defined. COPD stands for chronic obstructive pulmonary disease, which clearly highlights the major identifying factor of this condition: obstruction of the airways, making it difficult to breathe. This is a complex condition with many different factors, but for now, there's two things to remember about it. There's physical obstruction that makes air getting into the lungs difficult, and gas exchange is inhibited within the lungs. So we'll look into both of these ideas a little bit further.
So COPD is a mix of two different diseases, chronic bronchitis and emphysema. Chronic bronchitis is responsible for the physical obstruction that makes air getting into the lungs difficult. Essentially what happens is that the bronchial tubes become inflamed and make the passageway to the lungs narrower. On top of that, there's an increased level of secretions of mucus, which adds to the difficulty of getting air into the lungs. Emphysema, on the other hand, is a disease that causes the alveoli to become damaged and lose their stretch. Consequently, not enough oxygen enters the bloodstream.
So what does this mean for the patient? Shortness of breath will start occurring because of the decreased level of oxygen getting into the bloodstream, leaving patients in increasingly hypoxic states. Patients will have a productive cough as their system is trying to get rid of those extra mucus secretions. Because of the progressive nature of this condition, these symptoms tend to only get worse when unmanaged. Additionally, when COPD is advanced, it's known to cause several severe conditions such as skeletal muscle dysfunction, right-sided heart failure, depression, altered nutrition, and secondary polycythemia.
Next, we'll talk about exacerbations. Patients can experience episodes of symptomatic flare-ups called exacerbations. These episodes can persist for several days and range from moderate to severe dyspnea, coughing, and/or hypoxia. Multiple factors can be a cause for these exacerbations, but the most common are viral or bacterial respiratory infections.
The primary cause of COPD is smoking. It results in 80 to 90% of COPD cases in Canada. Additionally, working on job sites that are exposed to chemicals or air pollutants is a risk factor for developing COPD. Non-modifiable risk factors include increased age and genetic predispositions. An example of a hereditary risk factor is AAT deficiency, which is an insufficient amount of the protein antitrypsin, which is meant to protect the lungs from damage.
Next, we'll be looking through the nursing assessment for COPD. The primary goal of the nursing assessment for COPD is to determine the severity of the disease and how this disease is affecting the patient's quality of life. This is done by collecting comprehensive health history with a focus on smoking history. It is important to identify pack years to get an idea of the extent of the patient's smoking history. Pack years is identified as the number of packs smoked a day multiplied by the amount of years smoked. Additionally, the functional implications of COPD on the patient's life need to be assessed. Early in the disease progression, the patient may only experience dyspnea through strenuous exercise, but as the disease progresses, ordinary daily tasks may become increasingly difficult for the patient to accomplish.
When we talk about managing COPD, there are some priorities to keep in mind. This is often a progressive disease, so we're looking to prevent further progression. Reduce exacerbations, like we talked about earlier, alleviate symptoms, improve their physical activity, treat any resulting complications, improve the patient's quality of life, and reduce their risk of mortality.
First, we'll be looking into the non-pharmaceutical interventions for COPD. So priority number one is smoking cessation. This is the most significant factor in slowing the disease progression. Next, we focus on breathing therapy by incorporating pursed-lipped breathing, encouraging incentive spirometry, and ensuring effective coughing. Additionally, slow walking for 15 to 20 minutes every day has been proven to reduce severe flare-ups and to reduce muscle atrophy.
For pharmaceutical interventions, physicians will often prescribe bronchodilators as well as other PO medication to open the airway and reduce severe exacerbations. Secondly, O2 saturations are closely monitored in COPD patients and oxygen is applied accordingly. Though we're often told that O2 saturations should stay above 95, studies have shown that COPD patients have the best mortality rates when oxygen levels are held around 88 and 92%. The reason for this is that if there's too much oxygen, we decrease the patient's respiratory drive and consequently cause carbon dioxide narcosis, which is higher than normal carbon dioxide concentration in the blood.
So what can we take away from this? When you encounter COPD patients in your clinical rotations, remember to encourage effective coughing, diaphragmatic breathing, and the use of incentive spirometers. It's also really important to perform focused respiratory assessments, listening for any sounds of fluid or expiration wheezing. During the COVID pandemic, everyone is being extra cautious with infection control anyway, but being extra cautious with COPD patients is important because of the severe implications a respiratory infection could have on their health.
Thanks so much for watching. Have a great day.